A clinical trial is conducted to assess the effectiveness of novel formulation of Cisplatin for treating advanced non-small cell lung carcinoma. Study participants are randomly assigned to two different cisplatin based chemotherapy regimens. Subjects in the control arm were administered cisplatin, okay, whereas those in the experimental arm are given a formulation of cisplatin encapsulated in liposomes. This is basically a newer technology. All of you are aware of this. Nanoparticle coated. The newest advancement in pharmacology in anti-cancer nanoparticles. Liposomes encoded with anti-epidermal growth factor receptor antibodies. Patients in the experimental group are found to have a statistically significant decrease in the residual tumor burden compared with those in the control group. Okay. The incidence, that is the number of new cases present in a population at a given time. Prevalence is equal to incidence into duration of disease. Prevalence consists of old and new cases. Incidence is only the new cases into duration of disease. The incidence of adverse effects are also lower in the experimental group. Compared to conventional cisplatin chemotherapy, the new formulation is most likely to have which of the following effects? Okay. First of all, let us first try and understand the question first. Cisplatin chemotherapy. Platinum based chemotherapy agents like cisplatin, oxaliplatin, everything which has a platin. Cisplatin, oxaliplatin, all these are platinum based compounds. They are widely used as first line treatment for many solid tumors including non-small cell lung carcinoma. Okay, so how do they act? First we need to understand that. They basically disrupt DNA replication. All of you know DNA is a like this. Then the two strands separate during replication and then from one you get two. Yeah, you know all these steps, right, from your biochemistry knowledge. Fine. So USMLE is trying to test these concepts. They disrupt DNA replication and have substantial cytotoxicity against rapidly proliferating cells, hair cell, that is why alopecia, very important, infertility, sperm cells, spermatogenesis, very rapidly progressing thing, that is why. Okay. Despite their efficacy in killing tumor cells, their use is limited by severe adverse effects. Now they have nephrotoxicity, toxic to the kidney, ototoxicity, toxic to the ear, and myelosuppression. Bone marrow suppression, they decrease the red blood cells, white blood cells, and the platelets. Fine. Which occur due to accumulation within the normal tissue. These are also known as off-target effects. Off-target effects. So methods which provide targeted delivery to the tumor site can help minimize toxicity for optimized drug response. In this example, cisplatin is encapsulated in liposomes, as you read. See here. Active target. This is conventional chemotherapy. This is active targeting. Cisplatin, this is these green molecules encapsulated in a liposome, that is a nanoparticle, forming a nanoparticle cage. This is known as a nanoparticle cage. Nanoparticle cage that traps the drug and limits its interaction with the normal cells. So why do we use encapsulated nanoparticles? Obviously to decrease the adverse effects. The difference between adverse effects and side effects, tell me, I'm waiting in the beautiful comment section for your comments. Okay. So the addition of this in this example which you see, nanoparticle cage traps the drug and limits its interaction with the normal cells. The addition of anti-epidermal growth factor receptor antibodies, here you can see. This is EGFR, epidermal growth factor receptor. These are EGFR antibodies. The addition of anti-epidermal growth factor receptor antibodies on the liposome surface results in antibody drug conjugate. An antibody drug conjugate is formed, which allows the encapsulated drug complex to selectively bind to tumor cells. That is why we use nanoparticles. You must be asked that why do we use nanoparticles? So selectively to tumor cells, selective binding to tumor cells, expressing high levels of epidermal growth factor receptor, which is often overexpressed in non-small cell lung cancer. Now here one important thing which I'll tell you is EGFR is frequently expressed in which cancer. This can come as an MCQ. So you should remember lung carcinoma, breast carcinoma, in which epidermal growth factor receptor, all these are solid tumors, and glioblastoma. This can also be tested in your NEET PG, USMLE and PLAB exams. So here once bound, the drug complex is internalized and degraded, releasing the free drug and causing targeted cell death. Now, when you know everything, let us have a look at the options now. Decrease drug efflux from tumor cells? No. Overexpression of drug efflux pumps like P-glycoprotein by cancer cells is a major cause of chemotherapy resistance. Efflux pump inhibitors can decrease drug excretion from tumor cells and potentiate the effects of chemotherapeutic agents. But it is not the case here. Then, option B, enhance cytotoxic T cell response. Now, many cancers create an immunosuppressive microenvironment that prevents the immune system from effectively killing tumor cells. An enhanced cytotoxic T cell response against tumor cells occurs with the use of immune checkpoint inhibitors. Immune checkpoint inhibitors such as PD-1 and CTLA-4. This I'll be telling you in the subsequent slide when I'll be showing you the diagram of this. PD-1 or CTLA-4 receptor inhibitors, which help to prevent T cell exhaustion. We don't want the T cells to become exhausted. Then increased penetration through dense desmoplasia. Now what is desmoplasia? First you need to understand that. Desmoplasia is nothing but reactive growth of fibrous connective tissue, which occurs in response to certain tumors. Which tumors? This also you need to know. Breast carcinoma and pancreatic carcinoma. Desmoplasia is very often tested in USMLE, PLAB and NEET PG. Breast carcinoma, pancreatic carcinoma. The dense fibrotic tissue acts as a molecular sieve. This dense fibrotic tissue, this acts as a molecular sieve. जो होती है छन्नी होती है, उसमें छन के आता है ट्यूमर. So एक छन्नी बन जाती है. It acts as a molecular sieve, decreasing the penetration of chemotherapeutic agents. Chemoresistance is more likely to occur with larger drug complexes. In this case, जो new liposomal formulation दिया जा रहा है, that will be much larger than the individual cisplatin molecules, resulting in decreased penetration. So in desmoplasia, there is not increased penetration, but there is decreased penetration. So this obviously becomes false. Then choice D, inhibition of tumor-induced angiogenesis. So increased expression of vascular endothelial growth factor within tumor stimulates blood vessel growth of new blood vessels, which all of you know. That is how tumors grow and proliferate in our body, right? Angiogenesis, formation of new blood vessels. Because of vascular endothelial growth factor within tumor stimulates blood vessel growth, facilitating tumor expansion and increasing the potential for METs or metastasis. So here anti-VEGF antibodies, yes, you know their names, very good, excellent. If you said bevacizumab, full marks to you. Bevacizumab, that is a monoclonal antibody that inhibits this angiogenesis. It binds to VEGF and inhibits tumor-induced angiogenesis. Although EGFR stimulation also plays a role. Yes, it does. I'm not denying that fact. In this case, the anti-EGFR antibodies are used for targeting purposes and may not necessarily inhibit the EGFR receptor. Antibodies, you need to remember, they can be stimulatory, inhibitory, or they can have no signaling effect depending on the attachment site. 3 responses can be done. It is not that they will show response. So the educational objective that is being tested is antibody drug conjugates improve drug efficacy, that is a maximal response produced by a drug, and minimize the toxicity by allowing conventional chemotherapeutic agents to enter with fewer adverse effects. This is what I was talking about. Many cancers create an immunosuppressive microenvironment. The option B, right? That prevents the immune system from effectively killing tumor cells. Enhanced cytotoxic T cell response against tumor cells occurs with the use of immune checkpoint inhibitor. So what I told you, PD-1 is programmed death receptor and PDL1 is programmed death ligand here. MAB is monoclonal antibody, all of us know that, and CTLA4 is cytotoxic T lymphocyte associated protein 4. So here tumor inhibits T cell and evades tumor immune destruction, whereas here T cell stays activated and destroys the tumor cell. Anti-CTLA4 and anti-PD1. Bye.